Hello, hello, my friends. How are you today? Hello, Pamela in Kentucky, the great state of Kentucky. Hello, Nancy from Missouri. Pamela, fighting this for 18 years. Oh my God. It is how many years for me? I had my first symptoms when I was in seventh grade. I'm now 60 years old. But I am symptom free most of the time. And I want to help you get symptom free too. Hello, Carolyn. How are you? Hello, Maria. It's nice to see you too. Hi, Amanda. How are you doing today? Wasn't sure I was going to do this today. You know, we've been having stormy weather coming in. I've just had a headache for a couple of days. Like it comes and goes and comes and goes depending upon the air pressure out there. Oh, the joys of being sensitive. All right, so let me get my computer all set up here. Then my mom is not feeling particularly strong today. Let me take a peek at her. All right. So let me introduce myself. My name is Jill Osborne. I am the president and founder of the Interstitial Cystitis Network. I'm the longest serving IC support group leader in the United States at 27 years and counting, very close to being, if not. There might be one other group that's a little bit older than mine that's still holding meetings. That's a German group. But anyway, you know, this is my job, but I'm an IC patient just like you. I bring to you 3 college degrees. I've got a degree in chemistry. I've got a degree in pharmacology, drug development, which was a pre-med degree. It included a very rare surgical internship. Really quite proud of that. So I did surgery for a year. And then because I love animals and couldn't tolerate the animal research, I gave it up and went into psychology. I have a master's degree in psychology. I've got a presidential fellowship for my work in grad school. And ironically, the website, IC Network, was my doctoral dissertation proposal that I could not finish because it hurt too much to drive to school because of my own IC pain. But I'm very happy to say that 27 years later, that doctoral dissertation proposal is still ranked #1 in the world by Harvard Medical School and the University of London. So I bring to you a really unique kind of a different set of skills because I have a really hard science background, which allows me to read the research so that I can explain it to you. But I also have a really good kind of support background. My specialty was in groups. And how to help groups function better. Interestingly, my presidential fellowship, it's a really interesting situation where the White House pays your salary for 2 years, and you pick any job you want in the U.S. government. And so, and they pick 2 students per year. And so I got that in 1988, and I wanted to work for NASA. And so my first interview was at NASA headquarters in Washington, D.C. I met with this little tiny apple doll of a lady whose walls were covered with signed autographs of famous astronauts, right? And, you know, they love presidential fellows because they don't have to pay you. They just don't have to pay you. It's great. The White House pays your salary. And the job that she offered me was hatchet woman. I was to go down to Goddard Space Flight Center. Was it Goddard? I was to go down to one of the space flight centers and interview the managers and decide who to fire after the Challenger accident. Yes, it was that long ago. And I turned that job down because I didn't want to be hated. I didn't want to be hated. I had job offers all over the place. And then finally, the job offer I accepted was at Wright-Patterson Air Force Base working on the F-16 program. And that's a whole nother story I'll talk about in a whole nother way. That the office that I was supposed to go into, that I thankfully had not gotten into, was arrested for taking bribes. So, you know, the Lord works in mysterious ways. If there had not been some stumbles in the road in terms of getting me my orders to go to Wright-Pat to start that job, I could have potentially been in jail because the entire department was arrested for taking bribes from General Dynamics on the F-16 program. That's a whole other program. So anyway, you know, I just have this really weird background. Listen, I love being a support group leader. I love learning the research. My job is to make you so strong, so knowledgeable, so empowered that no one can mess with you again. I don't want anybody to minimize you, especially now that we've got the holidays coming up. Man, the last thing you need is to be sitting at the dinner table or even over a Zoom meeting with somebody who goes, aren't you over that yet? Like, what the hell is wrong with you, Jill? Seriously, drink some cranberry juice. Like that again? Are you kidding? That again? You just want attention, right? When are you going to grow up? When are you going to get a job? You know, the little crap that we all get, that we've all gotten at times when you've had a chronic illness that somebody else hasn't necessarily understood. And my job is to give you the knowledge, information, and education and power so that you can respond to that correctly. Because what you're going to say is, why, thank you, dear brother. I appreciate your good insight, your care for me and your kindness for me. But what you're missing is that you can't see what's wrong with me. That I have an injury in my pelvis, and it affects not only my bladder, but it also affects my muscles, and it also affects my nerves. And if I could wave a magic wand and make this go away, believe me, I would. I do not want to have this, but it is what I have, and it is my job to get through this, and it is my job to live my life. And frankly, I don't need your criticism. And if anybody continues to mess with you, I always just say, listen, get up, walk away. You don't need to take that crap. Denise says, I no longer get UTI since I moved and have a feeling my last apartment was full of mold. My dog and I lost a lot of teeth also. You know, Denise, we did a big article on black mold. We had an IC patient about 2 years ago who called us who had pretty severe aggressive symptoms. And but her whole family had a whole bunch of different types of issues. And what they found was a massive water leak into the foam underneath their carpet. And their entire carpet in their home was filled with black mold. They had no clue. And once they moved out of the house, guess what? Her IC symptoms disappeared. And that shouldn't come as a surprise because, you know, remember, we've got our own National Institutes of Health doing research on IC. And they're the ones who about 6 years ago discovered that some patients who are flaring have fungus in your urine. Fungus. That's not me making that up. That's from the U.S. National Institutes of Health MAP Research Network. They were the ones who proved that some patients who were flaring because they have an overgrowth of fungus, specifically Candida, different species of Candida. The last study that came out earlier this year found 13 different species of Candida. And what they found was that the more species a patient had, the more worse their symptoms. So I completely believe that if your apartment had black mold in it, that could be contributing to your symptoms. You would not be the first to say that. Hello, Amanda from Ohio. Hello, Jamie. Hi, Sarah. Hi, Carolyn. Hi, Cindy. Snowing hard in Eastern Canada. Yeah, I got my house is decorated now. So I've got some of my ornaments out. I hope that you are warm and safe and comfortable. And guys, listen, you understand that when you're under physical stress with extreme changes in temperature, right, that also is going to affect your body. And you might notice that you flare when it gets really, really cold or really, really hot, usually cold. Why? Because number one, your blood flow is changing, right? Your body is going to pull your blood flow into the core of your body. That's why your fingers kind of get cold and your feet kind of get cold. But also cold can cause your muscles to spasm. And if you're IC subtype 3 pelvic floor driven, or you got a pelvic floor component to your symptoms, that would explain why. Maria says, I started physical therapy thanks to you, got sacrum acupuncture on the first session and noticed a 50% decrease. Yeah, baby. Woohoo! Love it. Love it, love it, love it, love it. See, Sean says, good morning, Jill. Dealing with cloudy white urine, pain in the low back, urinating every 10 minutes, so frustrating. So cloudy urine and white urine is not a good sign. I hope, Sean, that you've got some azo test strips. You need to test your urine pronto. Y'all have this? Sean, if you don't have this, go test your urine, or honestly, I would call urgent care. Yeah, number one, your urine shouldn't be white. If it's physically white, that tells me that you probably have a lot of pus in your urine, which is a sign of infection. And the fact that you get pain in your low back and you're urinating every 10 minutes, that tells me that something significant is going on with you right now. But the cloudy white urine is a concern. And so if you don't have azo test strips, you can run down to a drugstore or have somebody in the family go get them. If you got a double positive, you got to call your doctor right away and let them know. And you're going to need a urine culture to see what type of infection it is, and potentially antibiotics, hon. Urine is supposed to be a pale, clear yellow. If it is dark yellow or brown, you're dehydrated. You're not drinking enough water. If it's clear, you're drinking too much water. There should be a yellow tone to it. White urine, that concerns me. That definitely concerns me. Amanda, I would definitely, Sean, I would call your doctor, whoever's on call, and tell them that you've got that today, like in the next 5 minutes. Amanda, I just got a ganglion block done last week. I see a little bit of difference. Awesome sauce. That's great. Brandy says, I've been dealing with my IC for 15 years so far. Diet and Botox have given me relief. Awesome. That's great. Brandy, it'd be interesting to know what subtype you are. Marcella says, I was just diagnosed and I've been uncomfortable for 3 months. My doctor put me on Elavil. So Marcella, understand that there are different forms of IC. IC is a bit of a grab bag diagnosis. For some people, IC begins in childhood. For others, IC begins after menopause. For some people, IC begins after chemotherapy because they have a chemical burn on their bladder. While for others, IC begins because they fall and injure their tailbone, right? They're all diagnosed with IC, but are they the same? Absolutely not. And so what doctor, and honestly, there's something else that we clearly know, and that is that a one treatment fits all approach doesn't work. Bladder therapies don't work for a lot of people, if not the majority of people. Why? Because we know that for a lot of people, it's something outside of the bladder, but also in their pelvis that's causing the issue. Usually some sort of muscle dysfunction, muscle injury, maybe a fibroid tumor, maybe endometriosis. It could be a central nervous system issue, could be something like that. And so what doctors, the top tier doctors, not the local doctors aren't doing this, but the top tier doctors are doing something called phenotyping or subtyping. We want to try to get a clearer picture of what your unique anatomy is so that they can talk about the right therapy for you. So as an example, they give you Elavil. Elavil is not a bad choice because Elavil will calm nerves down. The challenge with Elavil is it has a lot of side effects and it can make you gain weight fairly quickly. But when it comes to nerve-driven pain, Elavil is really actually a really good choice. The challenge, though, is that, again, it has a lot of side effects. Elavil, for me, gave me a regular heart rate. It really messed my heart up for years. And so I could not take Elavil. But, you know, I'm a redhead, super sensitive. Let me get my subtyping thing. Hold on a sec. All righty then. Here, hold on a sec. Let's just do this. We'll start this off the right way by going through your subtypes real quick. Here we go. I have the first hard copy of our new book on IC to proof this afternoon. Here, let me shut this door. All right. All righty then. So again, the top tier doctors around the world they're kind of in this informal competition, kind of contest to try to define the variants of IC because, again, not everybody's the same. So in Europe, there's 12 variants of IC using the European Society for the Study of IC Bladder Pain Syndrome system. In Europe, they require hydrodistension and biopsy, and then they rate you based upon what they see in your bladder and what they see with pathology tests. We don't do that in the US. In Canada, they use a system called Input. And in the United States, we don't have a nationally agreed upon system, but I use a system that was created by one of the top IC researchers, Dr. Christopher Payne, who ran the IC research program at Stanford University for 25 years, and he's now in private practice in San Jose. And he introduced his system in a really provocative way because he said, we should treat IC patients like cancer patients. And of course, in my brain, I'm going, oh my God, don't say cancer and scare people. But when you read his paper, which I happen to have, he says, no. Think about it this way. When somebody is diagnosed with cancer, they don't just say you have cancer and walk you out the door. They give you a very specific diagnosis. So you've got cancer of the left breast. It is estrogen dependent type 1, 2, 3. Or for me, a couple of years ago, complex endometrial hyperplasia with atypia and a vague architectural complex. What does that mean? Early uterine cancer, right? And so when you get a specific diagnosis with cancer, both you and the doctor know very quickly what the correct therapies are for you. And he argues quite successfully that a diagnosis of IC does not give the patient and the provider an intuitive treatment pathway. That basically you walk out of the room and they'll say, hey, here's a diet, maybe here's some Elmeron, and go read a website. That's typical. And so that's not useful in any way, shape, or form. We want you to have an intuitive treatment pathway here. So how do we do that? With specificity, with a more specific diagnosis. So Dr. Payne proposed 5 core variants of IC, and then there are some mini variants inside the main variants, right? And so sometimes they're called phenotypes or subtypes. I use subtypes because I think that's easier for people to understand. All right, so in his system, so here's his system. He's now at vistaurology.com in San Jose, California, and he is the premier pelvic pain provider on the West Coast. And his wife, Jeanette Potts, specializes in men with pelvic pain. Okay, so in using his system, subtype 1 is Hunner's lesions. Okay, Hunner's lesions or Hunner's ulcers. So these are the patients who have bloody wounds in their bladder, right? I mean, these patients have always been considered the most difficult to treat. They've suffered with intense pain, intense discomfort. They're often very diet limited. They're often down to eating 4 or 5 foods. And their condition, and they don't respond to traditional therapies. They just don't. And the question is why? So here we go. So let's look at a couple of pictures of Hunner's lesions. So a Hunner's lesion is characterized by what we call a stellate appearance. So there's usually a red center with arms that come off of it. And in the middle of this lesion is intense inflammation. The body is at war in these lesions. And that's what the biopsy results show. When you biopsy these lesions, you find massive inflammation. And that's a war. That's a biological war happening. That's your body fighting something. And interestingly, all the other subtypes don't have inflammation. It's just the Hunner's lesions that have profound inflammation. And also, too, it's just the Hunner's lesions where you see a deterioration of the bladder wall, that the epithelial layer of the bladder wall is damaged. You can see it on the slides. So what the hell are these? Well, there's two key theories. Theory number 1 is that it's a viral infection. And it was researchers in Europe who discovered that. It was researchers in Europe 5 or 6 years ago, again, who were doing extensive next generation DNA testing of urine. And what they consistently found in patients with lesions, but not in patients without lesions, is virus. Polyoma BK is a virus we all have. It is part of the human biome. We are not talking sexually transmitted disease in any way, shape, or form. We are talking just a normal part of the human biome. And normally this virus is silent. But in some patients who are immune compromised, the virus gets turned on. And when it gets turned on, it becomes an infection in the bladder wall. And so we have many studies already. We already know polyoma BK is strongly associated with what we call hemorrhagic cystitis. So we see this in patients who are really immune compromised or patients who are suppressing their immune system because they've had, say, a kidney transplant. And so again, think about this. It makes more sense. Could that be a viral infection? Fascinating. Absolutely fascinating. Now, the US government, the US National Institutes of Health was a little bit slow on the bandwagon. So we have multiple studies now from Europe that have found polyoma BK, Epstein-Barr. There's a little reference about a human papillomavirus, maybe herpes, but mostly polyoma viruses, right? And so I've been kind of waiting for a reaction from our own IC research community. And by golly, they were doing their own study for years. And what do you think they found? Polyomavirus. The polyomavirus in I think 5 to 10% of the IC patients that they studied, that it was an actual viral infection of their bladder. And the cool thing about that is that opens up a whole new line of therapy for those of you who have Hunner's lesions. And a whole new way of testing, because now we can use next generation DNA urine testing to see if you do have an active viral infection. And if you do, using an antiviral medication might be viable. And one of the things that I've been talking to patients about is, for those of you who get cold sores, I get canker sores. I don't get cold sores I think I've had one cold sore in my life. I normally get canker sores, which is a herpes simplex 2, which the great majority of the population has. And for those of us who do get that, one of the things that they give us is a lysine chapstick. And it's amazing how if you start using lysine, how quickly the infection goes away. It reduces its infection rate by like 50%. At least it does for me. And so, we're kind of talking a little bit about maybe using a little bit of lysine for patients who might have that. It's just an over-the-counter amino acid. It's interesting. Google it, see what you think. All right. Now, the other theory about Hunner's lesions is that it could be a nerve that is badly damaged, badly inflamed, that is releasing caustic substances, specifically something called substance P. Now, interestingly, lesions respond to lesion-specific therapy. You either cauterize them, which would kill the nerve that either the virus is living on or the nerve itself that's damaged. You could laser the nerve. You could inject a steroid into the middle of the lesion. That's also been found effective. We know hyperbaric oxygen therapy is showing good results. But here's the really interesting thing. We actually have a treatment, the only treatment in history that has healed Hunner's lesions in 2 weeks. 2 weeks. What was it? Called Lyris, also known as the lidocaine pretzel. So imagine a soft, hollow piece of spaghetti like this long. And inside that piece of spaghetti is medicine. And what they did is they put it, and it was invented at MIT. And it was a way to the bladder 24 hours a day, because the challenge with bladder diseases, how do you get the medication to stay in there? Because the reality is we pee it out usually fairly quickly. And so they created Lyris, Liris, that we call the lidocaine pretzel. So again, about this long, they put it up in your bladder and it kind of curls into a pretzel. And it stays there where it releases lidocaine 24 hours a day, 7 days a week for 2 weeks. Now, it was originally created for pain management. If you look at the early research studies that were done, it was all about targeting bladder pain. And the first study in Canada that was done, I think, by Curtis Nickel, the top IC researcher up there, they made a remarkable discovery. And that is, in the very first research study, which had maybe a dozen patients in it, and half of the patients had Hunner's lesions. And at the end of 2 weeks, the lesions were gone. Gone. And I had one of those patients called me and told me, I was like, what? And by golly, it took a year for them to release the data. And the quote in the research study was a total and complete resolution of the lesion. And think about it. It was lidocaine. What does lidocaine do? It numbs nerves. Now, there are some other methods of action. I don't remember what they were, but I did because I talked to the principal investigator at Allergan at the time. But lidocaine predominantly is known for numbing nerves. And now what are we saying about Hunter's lesions? That it could be nerve driven or it could be a virus living on a nerve. So Lyris was very, 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 very exciting until the company shelved it. And it is sitting on the shelf at Allergan. It's been sitting on the shelf at Allergan for the last 18 months. It is not available. And it is pissing me off because we have the first treatment in history that has healed lesions, non-surgical, and easy therapy. And we cannot get it right now. And I don't know why. The odds are it's probably because they didn't think it was going to make them enough money. That's my guess. All right. So I see subtype 1 Hunter's lesions. So let me just say right here, the thing that upsets me the most about this patient community is some of you have been diagnosed with lesions. You had a hydrodistension. They found the lesions, but they didn't do anything about it. It's like, wait a second, you're in there. You're looking at the bladder. The patient is anesthetized. This is the perfect opportunity to treat the lesion, and you don't freaking treat it? You're supposed to treat it at the time. That's the way it's normally done. So if you're ever going to have a hydrodistension, you need to make sure that you have a discussion with the doctor beforehand and say, okay, what are you going to do if you find a lesion? Are you going to treat it? If so, how are you going to treat it? And if the doctor says, I can't treat it, then you're going to say, maybe I need to work with somebody who knows how to treat what they will find. Let's see. Joe on YouTube says, a 24-year-old male here was diagnosed with IC at 13. It screws my life up so bad. So Joe, hang tight. Dude, hang tight because I think I want to talk to you. Okay, let's go to the second subtype. But Joe, I want you to pay attention to the third subtype. So give me 10 minutes to get there, and then we're going to come back to you, Joe. Okay, so IC subtype 1, Hunter's lesions. IC subtype 2 in the Chris Payne system is bladder wall driven. Because the bladder, like any other part of the body, can be injured. Now, guys, you got to remember, the bladder only has one language: frequency, urgency, pressure, pain. It feels like infection, even if it's injury. If you're going through chemotherapy and the chemicals from chemo are irritating your bladder, you're going to be convinced you got infection, because that's the only way the bladder can tell you that it's a problem, is with symptoms of frequency, urgency, pressure, pain. And the bladder, of course, can be injured. So the first thing we look for in this subtype is going to be chemical injury. So did you go through chemo, or are you drinking way too much diet soda or coffee? I was working with one lady, 7 espressos a day, way too much. Your bladder's not built to handle that. That's way too much. Oh my God, if I were doing that, I'd be in the hospital with heart palpitations. So the bladder can be injured with chemicals. That's number one. The second thing we're going to look for is estrogen atrophy in women. As we age, our bladders become a little bit more vulnerable because we lose estrogen, and your bladder needs estrogen to produce that nice thick coating of mucus that normally protects it. And when you're menopausal and you don't have estrogen anymore, everything starts to dry out. Things start to thin. So your vulva gets dry, your vagina gets dry, and guess what? So does your urethra, and so does your bladder. And that means that your bladder can't defend itself as well anymore. So it's very common for some women in their 30s and 40s to have been relying and loving that cup of coffee in the morning, and then miraculously one day in their 50s, they can't do it. Why? Because they're older and their bladder can't defend itself anymore. Their bladder simply cannot defend itself from that irritants in the coffee due to estrogen atrophy. So for those of you whose symptoms started after a hysterectomy, or or after you started birth control or whatever, you need to Google genitourinary syndrome of menopause, GSM, or estrogen atrophy or vaginal atrophy. because the quality and health of your skin is absolutely going to be playing a clear role in the way your urinary tract functions. The older you get, the less mucus you have, the more sensitive things become. One of the clear signs of that is urethral irritation. You might feel like there's a drop of urine in your urethra that won't come out, or there's burning as you pee, burning on your skin, on your vulva as you're urinating. Classic estrogen atrophy. The third thing we're going to look for, and Joe, hold tight, dude, I'm coming back to you. The third thing we're going to look for in this group is chronic infection. Because chronic infections happen. There's no doubt about it. But there are some people who say everybody has a chronic bacterial infection, and that's not correct. Because again, we now know that a lot of you might actually have chronic fungal infections. And so for those people who are saying you have to be on antibiotics, they're actually going to make a fungal infection that much worse. And of course, the tragedy is that typical urine testing does not test for fungus. It tests for bacteria. And so for a lot of you, here you're in agony. You call the doctor, oh my God, I think it's a terrible infection. They do a urine test, it comes back negative. One of the reasons why it might be coming back negative is because the urine test, it doesn't test for fungus. But next generation DNA urine testing does. And that's the future of urine testing, is doing a next generation test. And you're going to hear names of companies like Pathnostics and Microgen. Those are the companies that are doing it. They're doing all the COVID testing now too. Here you go. So if you want to learn about next generation testing, come on over to bladderhealth.org, which is a website I built on that 2 years ago, and check that out. It's really cheap now. It's like $199, and it'll tell you once and for all. You know, like I like data. I don't like guessing. I like facts. If you've been in pain for a long period of time and you're not responding to therapy, the American Urology Association says, take a step back and reconsider the diagnosis. Have we missed something? Have we missed something? And the odds are, yes, you really might have missed something. And so that next generation test will either rule it in or rule it out. Data. And again, a lot of you are self-medicating on antibiotics. Every time you have a flare, the first sign of frequency, you grab those antibiotics that you got sitting in your bedside table. And the challenge is when you keep doing that, you are creating more fungus and you are creating an environment for drug-resistant infections. So rather than guessing, get some facts, have a test, just have the test, see what it says. And if you're positive for, let's see, what was it? Enterococcus facialis, that's interesting. If you're positive for ureaplasma, mycoplasma, those are interesting. Those are actually kind of challenging chronic infections to treat. So it's going to be very interesting to see what they find. And if they find candida, then we know that you're going to have to do an antifungal program. So, and yes, there are some people who do have chronic bacterial infections, but again, no all or nothing statements. We can't do the all or nothing statements anymore. We now know that viruses are at play, we know that fungus is at play, and we know that bacteria can be at play. But in this whole subtyping system, that's still a small community of you. Because now we've got to get to the next subtype, which is the biggest subtype, and that is pelvic floor driven. Now, we knew so if you go back 100 years and you look at the research papers and the case studies that doctors put in medical journals, urologists put in medical journals about IC, they describe muscles so tight they resemble tight piano strings. But of course, urologists stay in their box. Urologists like to stay in the urinary tract. So even though they're like, yeah, man, look at that muscle. That's really tight. That is so weird. They didn't do anything about it. And it was thankfully due to a physical therapist named Rhonda Cotterinos, who back in the late 1990s and early 2000s, who actually came to IC events and said, hey guys, have you tried physical therapy with any of these patients? I'm doing physical therapy and they're getting better. And of course, the doctors laughed her off. They literally walked out of the room when she started talking at the first conference. Well, she was right. And in 2000, she was able to convince the National Institutes of Health to do a research study on it. Does pelvic floor physical therapy help reduce the symptoms of IC? And what do you think happened? In 2008, the data came back and it was stunning. Pelvic floor physical therapy not only helped, it was better than any other IC therapy at reducing the symptoms of IC. All the oral medications, physical therapy beat. And it was at that moment that the IC world turned on its head, because up to that point, everybody was thinking bladder, 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 incurable bladder disease, bladder, bladder, bladder. But when that study came out, it was like, oh, wait a second. A muscle therapy helped a bladder disease? What? And that was really the first start almost of subtyping. Really, because at that point in time, no one could ignore the fact that patients had tight muscles and the consequences of tight muscles. And the consequences of tight muscles are restricted blood flow to the bladder and damage to the nerves. So again, in this whole subtyping system, we really think, I personally believe that the pelvic floor subtype is by far the biggest subtype, because I've worked with you guys for 27 years. I work with patients almost every day. And it's so interesting when you go back in time, the number of you who have physical trauma. And so I want to get back to Joe here on YouTube. Is it Joe or Joel? I apologize if I have mispronounced your name here. Let's see here. Hold on a sec. It's Joe. Good. No, yeah, it's Joe. So I'm going to tell you now. This might be kind of controversial, but this is my opinion, because my first support group was filled with men back in 1993 when I started my group. I spent a lot of time with men. It's kind of my subspecialty in this movement. When I work with men and we go back in time, especially for guys that symptoms started when they were younger, we can almost always find a pelvic trauma. Falling on your tailbone, jamming your crotch on the bar of a bicycle, a long motorcycle ride, a long bicycle ride. So Joe on YouTube, you're 24 years old. Your IC symptoms began at the age of 13. Can you remember any physical trauma? Can you remember, were you in a car accident? Were you in a bike accident? Did you fall down a flight of stairs? Did you fall on your tailbone? Did you break a leg? Do you remember any physical trauma? Now, again, muscles can trigger symptoms of frequency, urgency, pressure, pain, but the symptoms are subtly different. So if you've got a bladder wall injury, you're going to have discomfort as your bladder fills with urine that is relieved when you pee it out. And there's a very simple explanation for that. And that is that, all right, where's my picture? Here it is. So think about it this way. If you've got a bladder wall issue, as your bladder fills with urine, fuller, urine is getting into the wound. Of course, that's going to hurt. But as soon as you pee, bam, urine is no longer in the wound. You feel better. So the hallmark symptom of somebody with a direct bladder wall issue is pain as their bladder fills with urine that is relieved by urination. Pelvic floor is subtly different. Instead of having pain when your bladder's full, you tend to have more pain after you're done peeing. It's a duller pain. It's an achier pain. Bladder wall pain is very sharp and shrill. It feels like ground glass. It feels like razor blades. To me, when I was having bladder wall pain, it was like claws ripping down the inside of my bladder wall, like really sharp claws. Totally freaky and obviously agonizing. Pelvic floor pain is duller. It's achier. It has a burning quality to it, because a muscle that's working hard is a muscle that builds up lactic acid. So you're going to notice burning. Bladder wall pain does not normally burn. Pelvic floor pain burns. For women, it can be a vaginal burn. For men, it can be a rectal burn. It can even be pain referred to the tip of the penis. Okay. But the hallmark symptom of somebody with tight pelvic floor muscles is that when you go to pee, you can't pee right away. That you hesitate 5, 10, 15, like, you're trying to relax. so that you can release urine. And some of you, you're impatient and you start pushing. And when you push, you're actually making your muscles tighter. You should never strain when you're trying to pee. Okay, so Joe says, I have no lesions, only severe pain, pressure, and small capacity. None of the conventional, okay, so he said, none of the conventional treatments or pelvic floor therapy did for me, and diet didn't help. All right, so Joe, you went to pelvic floor. Tell me, what did they find when they did your pelvic floor assessment? What were your muscles tight or were they normal? Were they tight on one side and not the other side? What did they find? I am very, 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 very curious. So, muscle injuries can happen after a bunch of different types of events. They can happen again with some sort of physical trauma, but they can also happen after you have a baby. They can happen. I've had several patients who have been hit by cars when they were kids. We've had several patients who have fallen down stairs. Tragically, we certainly do have a group of patients who were the victims of sex, where there was, pretty significant trauma in that case. But in other cases, sometimes it's a mechanical trauma that it might not be actually a mechanical injury. There might not have been a time are putting significant pressure on your pelvis and making them tighter and tighter and tighter. So if you've got one leg longer than the other, that means your hips are going to be slightly off. And so as you're walking like this, and your pelvic floor muscles are getting tweaked that way. Or if you've got a bad hip, or if you've got a bad SI joint, or if you've got a bad knee, or if you've got bad feet and you're not walking normally, this can all put dysfunctional pressure on your pelvic floor that over time will cause those muscles to get tighter and tighter and tighter. So again, so let's look in Joe. Let's see if Joe has responded then. He hasn't. All right. So let's go to the next subtype. So remember, subtype 1, possible viral infection. Subtype 2, bladder wall injury. Subtype 3, pelvic floor injury. Well, look at this. Subtype 4, a nerve injury, pudendal neuralgia. Pudendal neuralgia. So this is a patient whose positions are positional in nature. Natalie on YouTube says, have you heard of mold and it being correlated? Yes, we talked about that early on. Absolutely. Patients who have black mold in their house will often have symptoms of frequency, urgency, pressure, pain. All right, so let's go back to this. Subtype 4, a nerve injury. If your symptoms are positional, you're fine when you stand, but when you sit down, it hurts. You sleep well at night until you sit on the side of your bed in the morning, then it hurts. If you got sciatica, if you got pain shooting down your leg, if you've got tingling, if you've got pins and needles, if you've got numbness, but mostly if your symptoms change as you move, that's a sign that you've got muscles so tight, they're now pressing on a nerve. Pudendal neuralgia. The classic symptom of pudendal neuralgia in women is going to be PGAD, persistent genital arousal disorder. You're going to feel turned on, but it hurts badly. It's totally freaking creepy and disgusting. I had it for about a month. I call it one of the dirty secrets of IC because when you have it, you don't want to tell anybody about it because you don't want them to think that you're a weirdo and that you're getting some sort of weird pleasure over this whole thing, if you know what I mean. It's a very important symptom to tell your doctor because that's a very clear sign that the pudendal nerve is being entrapped in some place. So therapy for this is obviously going to be figuring out which nerve is entrapped, releasing the entrapment, and that's usually tight muscles. So we've got to release those muscles and do physical therapy. But sometimes it's an adhesion. Sometimes it might be endometriosis, might even be a birth defect. But there is hope for this group too. And for the person who said the doctor gave her Elavil, Elavil is really an important therapy in this group because Elavil will act to calm this nerve down, but so would gabapentin. And so when you got a super irritated nervous system, we want to try to calm the nerve down. And that brings up our last subtype, which is central sensitization, IC subtype 5. Now, these are the patients who have really sensitive skin, like me. You can tell I'm only wearing cotton. I can't wear anything else. We tend to be drug sensitive. A normal dose of medication is too strong for us. We tend to be food sensitive. There's some foods that just don't work well in our body. For me, that's oatmeal and chocolate. I'm sick as a dog for days if I eat either one of them. The hallmark symptom is a wicked sense of smell. We can smell things that other people can't smell. The smells drive us absolutely crazy. Like my dad yesterday decided to try to clean part of the oven with Windex. And I told him as I walked by, I said, please make sure you rinse it off. He didn't. I was going to make peach cobbler last night, turn the oven on. Woo! Hot Windex throughout the kitchen. And then I opened up the oven and it's like, oh my God. It's like, oh. Turn the oven off. I've washed it 5 times so far to get the Windex out. I think I finally did it, but he sprayed it onto the insulator around the door. So, we are incredibly sensitive to chemicals and smells. Like we have to run out of the house. Like the time 2 years ago, he tried to wash part of the garage floor with, what's that super stinky stuff? It's like the guy's cure-all for in World War II. Oh, the name will come to me. Okay, so in this subtype, sometimes sensitivity is inherited. It is inherited in my case. Hello, redhead Norway. Every woman in my family going back generations has this. I mean, we couldn't use bubble bath when we were kids because it irritated our skin. But for others, central sensitization happens after trauma. Think about the old timers. Well, some of you aren't old timers, but you got, in fact, I love BTS right now, the Korean K-pop group. Oh my God, I love BTS. I just there because I can't drink coffee. And so I turn them on in the morning. It gives me so much energy. I love listening to them. And Suga, one of the singers, just had shoulder surgery. And he was actually talking about this. I was watching last night an interview he was doing and some of the symptoms that he was having, that when you have kind of a long-term chronic injury that causes pain, the nerves start to change and they become more sensitive. And that sensitivity not only is in the area of the injury, it can then spread to the spinal cord. And now we've got a sensitive spinal cord, which can then spread to the brain. Now, the cool thing, and a sense of smell is all about brain function. Smell isn't determined by your bladder or your spinal cord. Your sense of smell is up here. So I attended the International Pelvic Pain Society meeting this year, and it was stunning. It was last month. Absolutely stunning because they are almost curing this. But it's all about understanding what's happening, that when you are under long-term intense stress, and when I mean stress, I mean physical stress, pain, but also emotional stress. Obviously, we're all fearing for our lives with COVID and things like that. It's not like your brain is passive. Your brain is responding to all of that. And long periods of stress, whether pain or whatever, will cause your brain to respond to that. And we can see that in brain studies. We can see that different portions of the brain get bigger, other portions of the brain they change how they communicate with each other. Because the brain, when you look at brain function, it's like a lightning storm. Different parts of the brain light up as different things are happening. It's really cool. And if you were a musician and you grew up playing the piano, your brain is different than somebody who didn't grow up as a musician. Our brain adapts to our environment really, really well. And so what we find with central sensitization and chronic overlapping pain conditions, so people who have got fibro and IC and vulvodynia and irritable bowel and sensitive skin and TMJ, what we're finding is a lot of that's being driven by maladaptation in the brain, that the brain has reacted to a long period of stress. And so how do we fix that? We retrain the brain. Man, you could be doing bladder therapies for years, but until we calm the brain down and we try to retrain the brain to start interpreting stress correctly, you're always going to overreact to pain. The nervous system becomes more sensitive. That's what we got to try to address. And so, now listen, a lot of you, myself included, you get furious when somebody says, you need to take an anxiety management class, or, hey, have you tried meditating or whatever? It's like, hey, shut the F up. It's in my bladder. Don't talk to me about that. My bladder is screaming at me. That's how I felt when I was diagnosed. And my doctor said, maybe, there's this really great book called Mindfulness. You should read it, by Jon Kabat-Zinn. I think you'll find it really helpful. And I'm like, what the hell are you talking about? My bladder is screaming. Please give me pain medicine. Please help me. I don't want to hear that crap about mindfulness. Don't tell me about that, right? And guys, hello. I walked into this with a lot of medical training, and I didn't get it. And it really wasn't until a lot of the brain studies started coming out about 5 years ago with IC patients and IBS patients that you can actually see it. You can actually see the brain is definitely reacting to, in some cases, injury. It happens after an injury. Some of you, for example, you want to be that person who never takes pain medicine. Man, I'm not going to take pain medicine until I'm bawling my eyes out. But you're not understanding the toll that pain is taking on the rest of your body. And that's causing your spinal cord to respond to the pain. That's causing the brain to respond to the pain. And if you have long-term pain that you're not dealing with, that your brain is going to continue to change in a negative way. So we got to turn it around. We got to retrain the brain how to respond correctly instead of incorrectly. They call it maladaptation. And the research from Harvard Medical School is nothing short of breathtakingly good. That for patients with chronic overlapping pain conditions and central sensitization, the correct therapy is, number one, to address the pain wherever it is. Like if you got a painful bladder, for God's sake, don't be drinking cranberry juice or coffee. Our goal is to calm the nervous system down. We got to calm everything down. And how do we do that? We do that with, I'm going to say it, mindfulness. Mindfulness. We do that with progressive relaxation. It's just about you. You know how we say you are an anatomical mystery to be solved, right? We got to understand your body. And for those of you who have muscle issues, it's like, okay, dude, you got tight muscles. What do you know about the muscles? And a lot of you are really passive. It's like, okay, it's a muscle, so what? Now you got to learn. You got to learn the different muscles down there. You got to figure out where your muscle problem is and learn how to treat it. And the same is true with sensitivity. It's like there's no shame in it. It happens when you get hurt or you're inherited. I didn't do anything wrong. It was never my fault. And I spent most of my 20s, guys, listen, even though I was really successful in school, I was miserable because I didn't understand my freaking body. All my friends were out getting married, dating, getting married, having babies. I was at home laying on my freaking bed with bowel spasms every morning for 5 years. What the hell was that? Oatmeal. I'd become sensitive to oatmeal. What did my doctor tell me to do every day? Eat oatmeal. When I finally stopped eating oatmeal, the spasms went away, but I lost a lot of time and I became very, very depressed. But now I know I did nothing wrong. This is inherited for me. It runs in my freaking family. It wasn't my fault. It never was my fault. And it's not your fault too. So if you inherited sensitivity, okay, it is what it is. It's a landscape. You got to learn how to protect your body here. For those of us who are sensitive, we don't do well in the city with lots of noises and stuff. We do better in the country. Not everybody was born to be a trial attorney. Some of us are born to be writers and artists. It's about finding where your body thrives. When you're young, people say that your career has to be something really powerful. But you know what? Everybody told me go work for the government. I was miserable. The work was easy. Could have done it with my eyes closed and my hands tied together. Work could not have been easier. I was physically miserable. I was physically miserable. And when I got out of the city and into the country, guess what? Things calmed down. This is about calming your nervous system. And so, again, if you have chronic overlapping pain conditions, there's the Chronic Pain Research Alliance. Just Google it. Chronic Pain Research Alliance has been studying this for over a decade. And their research is absolutely phenomenal. Now we understand that, yes, you have bladder symptoms. I have bladder symptoms. You got bowel symptoms. I had bowel symptoms. You got sensitive skin. I have sensitive skin. You got a wicked sense of smell. I got a wicked sense of smell. It comes back to our nervous system. And it's so exciting that we can now treat it correctly. And on our website, icnetwork.org, I have, in one of our pull-down menus, I have links to the guided relaxation for pelvic pain CD. Well, they're now online. Okay, you can just listen to them there. These were studied by the top IC research center in the United States, Beaumont Urology, and were proven to reduce pain and symptoms in IC patients. They are free on our website. You need to be listening to at least one of those a day, because this is about you taking control of your stress, you taking control of your anxiety, and you calming your nervous system down. If you are struggling with massive catastrophizing, you are amping your nervous system up. Pain that is accompanied by anxiety will be intense. It will be intensified by the brain. Pain that is accompanied by laughter will be minimized the brain. We got to calm everything down. We got to get this anxiety under control. We got to get the catastrophizing under control. We got to calm the entire central nervous system. And you know, the thing that was amazing for me, now realize that when my IC started at the age of 32, I had already had IBS and vulvodynia. I already had all that in my 20s. I had a doctor say to me, "You will forever be a burden on your family. You will always live with severe pain. Get used to it. This is your life." And that is what woke me up. Because up to that point, I was passive and a victim, staying in my bedroom. I got pissed. I got so pissed. I said, "How dare you say that to me? I will prove you wrong, you son of a bitch. How dare you say that to me?" And I did prove him wrong, because I'm pain-free now. And I have been I'm mostly pain-free for the last 15 years. Why? Why? Well, the first thing I did is I learned a lot about IC. I started reading everything. Number two, I recognized that I had massive anxiety, that I would have a panic attack. I would have to go do deep breathing in my backyard before an hour or two before the appointment, because I'd have a massive panic attack. And one day I was just like, I can't do this anymore. This is terrible. And I took an anxiety management class at my local hospital. Oh my God, it completely changed my life. Instead of catastrophizing 24 hours a day, spinning in a loop, going, the world is over, the world is ending, I am unlovable, nobody will care for me, my life is over, all those things that I know some of you are doing, you're spinning in a circle in massive anxiety. Guess what? It stopped, because I have the skill to deal with it now. I have the skill I learned how to control anxiety. And now I never let it get to the point that it can become a problem. And I've talked about that. I've got a video on our website, Anxiety and IC, that you can watch if you want. So that was the first thing I did. And what I didn't know was that I was calming my sensitive nervous system massively, because I didn't know that anxiety drives and intensifies pain. So this one class calmed everything down. That was pretty cool. But the second thing I did is kind of a variation of mindfulness. Mindfulness means, let's see, we had a therapist come to our support group, and she talked about the runaway train of pain. That when you're in pain, and if you have a sudden flare, you're going to have an emotional reaction to that flare. Who doesn't? When you're in pain, it's scary. But her question is, do you have to have the emotional reaction every time? I mean, you know what it is. You drink coffee, you hurt your bladder, it hurts. You know it's going to be okay. It's going to be okay in a couple of days. Do you have to have the, oh my God, the sky is falling, my life is over, emotional reaction every single time you have a flare? And the answer is no. She talked about learning how to step off the runaway train of emotion when you have a flare. And I started doing that. It's like, okay, it's a flare. I get it. I'm ovulating. It's my ovulation flare. Okay, yeah, no. I ate something I shouldn't eat. It's a flare. And I just stopped allowing myself to overreact to the flares. It's like, all right, it's a flare. I know what I did. And then the third thing that I did, which I think was probably the most important thing of all for me personally, is that when you have anxiety, the world is a very negative place. Every thought you have is negative. Somebody says, hey, you want to go take a drive? You're going to go, nope, going to have to pee. Hey, you want to come over? You want to go out to a movie? Nope, going to have to pee. It's going to hurt. No, can't do it. The food is going to hurt me. And before you know it, your anxiety and your negative thinking is saying no to everything. Even today, if somebody says to me, hey, you want to go drive up to Tahoe? I'm still probably going to immediately go, no, because that's a hard, long drive for somebody with a pelvic floor issue, which I have. But I didn't know I was doing it every single day, almost every single minute. And somebody gave me a Norman Vincent Peale's The Power of Positive Thinking. And he talks just really about retraining your brain from the negative to the positive by filling your daily life with positive things instead of negative things, like having affirmations everywhere. You can see on my back wall, what do I have? Believe. See that right there? Believe. Love. I live in a happy home. I have affirmations everywhere. I can do all things through Christ who strengthens me. Every day in every way, my life is getting better and better and better. That which is done for you, let it be done. That which you must do for yourself, do it. It's about finding an affirmation that works for you, that resonates for you, and saying it. I had my affirmations that I read before every doctor's appointment. I was sitting there, they were on little cards, sitting in the doctor's office, just reading them. I can do this. I can do this. I can do this. I can do this. And you know what? I retrained my brain. And that's why I'm better. So now I really understand why I no longer have vulvodynia and IBS and I see bladder pain very much, is because I have learned to calm my nervous system down. And again, we see that with brain studies. It is proven with brain studies. Harvard Medical School. My next IC Optimist magazine, which I should be writing right now today, as a matter of fact, is really going to go into this in depth. So those, my friends, are the 5 core subtypes. Hunner's lesions, bladder wall injury or chronic infection or estrogen atrophy. Number 3, pelvic floor injury, which is our biggest subtype. Number 4, pudendal neuralgia. And number 5, central sensitization. Those are our core variants. So please, when you look at the AUA guidelines for IC, step 1, what's in there? Diet modification, improving your water intake, trying supplements, because supplements carry far fewer side effects than traditional medications, and muscle relaxation, and acupuncture and guided relaxation, because they're trying to reinforce to you that your skills matter. Your ability on a daily basis to integrate some of these is going to be crucial to you getting past this. And again, some of you are spinning like this, and it's just no, don't talk to me about any of that. It's my bladder, F you. Look at the other symptoms. If you've got sensitive skin and wicked sense of smell, it's not just your bladder, it's your nervous system. And that's different. And we can work on that and improve that dramatically. All right. So there you go. Those are the 5 core subtypes using the Chris Payne subtyping system. I'm going to tell you again, your local doctor probably doesn't know crap about this because only the top tier doctors are doing this. If you have a doctor who, I always say, now listen, when you go to a new doctor, for God's sake, don't walk in and say you have IC. It just happened to somebody here in my town. The doctor said, I don't treat IC. And wouldn't even see her. Do not say that. You have to walk into your doctor's office and focus on your symptoms. Hey, doc, I had pain on the left side of my penis in my testicle area. Or, hey, doc, it's so weird. I can't sleep through the night. I get up to pee all the time, but it gets really bad when I sit down on the toilet. But when I stand up, it's better. Or, hey, doc, I got the symptoms of frequency urgency, but what's so weird is it feels like I'm carrying a bowling ball around in my pelvis, or I feel like something's falling out of me. See, your ability to describe your symptoms in depth and the little tiny symptoms. Don't just say it hurts down there. If you do that, that pisses me off. You got to be specific. Is it inside of your body or outside of your body? Is it on the left side or it's on the right side? Is it low? Is it high? What makes it better? What makes it worse? These are the things you've got to come into that meeting prepared to discuss. You need to focus them on studying your pelvis. If you, as a woman, feel a downward sensation, like something's falling out of you, then you have a muscle issue. That in all likelihood means that you've got weak pelvic floor muscles that are starting, you might be developing a prolapse of some type. If you have pain, is like something's being shoved up inside of you, that's also a symptom of muscles. If you feel like there's a foreign object stuck up there, that also is a sign of muscle issues. If you, if it runs in your family, you've got to tell them it runs in your family. My mother had this, my grandmother had this, whatever. And most importantly, go back and think about traumas. Go back to, listen, your intuition is vital here. A lot of you, like the person who said, hey, my symptoms started after I started birth control and the doctors didn't believe you. But when you stopped the birth control, your symptoms went away. Okay, your intuition is important here. So what do you think triggered your symptoms? Did it happen after having a baby? Okay, then let's look at that childbirth. Did something get torn? It's just, listen, the diversity is real here. We are so far past thinking IC is an incurable bladder disease. We don't think that way anymore. There is a depth and breadth to this community that's nothing short of astonishing. And when Dr. Payne wrote his subtyping system, he said flat out, the worst thing, the biggest crime that's happened to the IC patient community is you're all told it's an incurable bladder disease. And he said, the reality is that for some of you, it is curable. It is curable because we have to know what we're treating. If you have a fundamental muscle issue, that is curable. If you have a pudendal neuralgia, that is potentially curable. If you have central sensitization that is inherited like me, okay, that's not curable. That's my body. It's my job to learn to live with that. If you have an injury that's resulted in chronic overlapping pain conditions, that is, I don't know if we can say curable for that, but we can certainly restore brain function. And when we restore brain function, what happens? Symptoms go away. So there's really, really good things happening. All right, man. Can I talk? Kratom on YouTube says, I have horrible adhesions from multiple surgeries that I think caused my IC. Yeah, so really, you guys try not to use the word IC. Try to be more specific than that. Kratom, could we say I had horrible adhesions from multiple surgeries that I think caused my pain or my frequency urgency? Okay, let me look down here. Natalie said, okay, hold on. I don't know what happened to Joe. Joe, if you're still there, I would love to talk to you this week. Please give me a phone call at the IC Network office. I work with guys almost every day. Donna, don't forget my IC family. Joe will be doing Zoom, and that is another way to connect with her in person. Yes, I will be doing Zoom. I wasn't planning on doing a long meeting today because what do I have here? Woohoo! Look at this baby. The first hardcover print of the new book on IC. First chapter, subtyping IC BPS. Yeah, baby. Been working on this for a year. Also, just so you know, another bit of exciting news here. I am now published by Harvard Medical School because I was asked to contribute a chapter on pelvic pain last year. I almost forgot I did it. Wrote it last year. And so, yeah, we've got another book on pelvic pain coming out too. Pretty good for, I didn't get the PhD, but I in my opinion, I kind of have a PhD in living with IC. So there you go. All right. Well, let's take your questions now. You've heard enough about me, and I'm now probably way behind in your questions. I'm sorry. Pamela, how do you find out if it's fungus? My house is flooded more than once. Next generation urine testing will do that for you. Hello, Patricia from Washington, D.C. Oh, girl. I wonder what it's like in Washington, D.C. right now. I have a friend in Washington, D.C. He was getting ready to move. He felt it was really scary to live there. I hope it's going to get better in the coming months. Let's see. Guys, remember, if they prescribe an antidepressant, there's a valid reason for them doing it. They're not telling you it's all in their head. The antidepressant will actually physically calm nerves. Julie says, thank you for the Cystomend. I am using them now. So you guys, again, the American Urology Association in step 1 suggests using supplements. Cystomend is our newest supplement. Let me get it for you. All right. So now that the only oral FDA-approved drug for IC has been linked to pretty severe eye issues, patients are transitioning to supplements or bladder installations, either or, your pleasure. And the supplements that are commonly used are going to be bladder builder. You're looking for a chondroitin-based supplement that can help restore the integrity of the bladder wall, or bladder rest, or Cysto Renew, although this is out of stock and the company has not explained why, so we haven't been able to get this for about a month. No clue what's happening with Cysto Renew. The old favorite, Cysto Protec, was created by an IC researcher 20 years ago, Dr. Theoharides, and then the newest one is Cystomend. And Cystomend is like Cysto Protec, only with the addition of a pumpkin seed extract, antioxidant and anti-inflammatory. So Cystomend is something, listen, everybody's different. There's not one thing that works for everybody, but the good news is, unlike 5 years ago, at least we got lots of things that potentially you could try. Joe is back. Sorry, back now. The assessment said they were tight, and I guess the therapy helped a little, but the pressure and the small capacity were still there after months of pelvic floor physical therapy. Maybe I just didn't stick with it. Joe, I'm going to tell you. So, I was working with a 23-year-old, like right around your age. And actually his mother called me because he was so despondent. He was not willing to talk to anybody. So his mother called me first and we started talking, and it turned out he was a high school football player. And it's like, all right. So I was working with a Denver Bronco football player last year who suddenly developed frequency urgency. Professional football player this happened to. Well, it happens to a lot of high school football players too. And so when we started talking about the concept of muscle injury, she was like, oh, let me go get him. And he actually talked to me, right? Which is so cool. I love talking to younger people who have IC because I want to comfort you and tell you it's not your fault. That's the best part of my job. So anyways, get him on the phone. It's like, all right, dude, take me back in time. Take me back in time. When did this start for you? He goes, I can tell you exactly when it started. It's like, okay, when? He goes, my football team went on a ski trip and I fell off the ski lift. And it started that night. Now realize his doctors had only given him antibiotics and bladder therapies. Nobody had assessed him for muscle issues. And he didn't tell them that he had fallen off the ski lift, and his symptoms started hours later. And so Joe, I see so much of that in guys. I can't begin to tell you. I think great. I'm going to say 90%, maybe even more of the men that I work with, especially younger guys who have these symptoms, we can almost always find a physical trauma. Like he says, I was diagnosed at 13 and I did play football at the time, but not in high school. I can't recall a pelvic injury, but it's certainly possible. Were you a big bike rider? Motorcycle? Did you have a Stingray? We had one research study that showed if you, as a guy, jammed your crotch on the bar of a bicycle even once in childhood, that by your 30s and 40s, you would have frequency urgency. And that was a paper published by the American Medical Association several years ago. Or were you an ice skater? Play ice hockey? Kim says, how do I know if I have IC or endometriosis? Patients with endometriosis have agonizingly painful periods. Agonizingly painful periods. And so if your periods are normal, you probably don't have endo, but you can ask the doctor to look. You can do a sonogram and see if you can see anything unusual. Patty says, I've been doing pelvic floor therapy. In my last session, my therapist said she could tell there was less muscle tension. Yeah, baby. Love it. Not really, but I should start that pelvic floor. He says, I really should start that pelvic floor therapy again just to try. Yeah, you should. Honestly, you should. But Joe, before you do that, I need you to get a book. Actually, no, wait, hold on. So one of the things that always surprises me is that when people say it's your pelvic floor, you're like, okay, it's a flat muscle at the bottom of my pelvis. And it's not. Your pelvic floor goes from left to right, front to back, low to high. It has 3 layers. And so when you go to have a pelvic floor assessment, it's really important that you walk in knowledgeable so that you can say, hey, I think it might be my levator on the left side by my tailbone, or hey, it might be up on my hip bone, right? If you can walk in and at least have a basic knowledge of kind of where the muscles are and what they do, like, for example, if you get a lot of sharp back pain, you've got really ropey, they're like this thick psoas muscles that go from your pelvic floor up into your lower back. And it goes right along both sides of your spine. Man, when those psoas muscles get tight, it hurts. That's where I get a lot of tension. So to everybody out there, the book that I believe will change your life if you think you have a muscle issue is this book, Breaking Through Chronic Pelvic Pain by Dr. Jerome Weiss. This is a masterpiece of book. It is a master class in anatomy. And it will it's just, I've read it twice. I'm going to read it again. You can see I highlighted lots of areas that I thought were particularly important. The diagrams in this are astonishingly good. Here's a picture of a trigger point in your pelvis that becomes a long-term chronic muscle injury that then starts to compress blood vessels, which then damages nerves. I mean, it's just so freaking good. It's so good. It's so good. I love this guy. And it's written from the perspective of men and women. And so the diagrams were their diagrams for male anatomy and female anatomy. And here's the thing, guys. It's free on Kindle Unlimited. So no excuses. For God's sake, educate yourself before you go to the doctor. This is $29 from the IC Network on Amazon. Love this book. Another series of books that is also really, really good, but it gives you more things that you can do at home, are going to be Isa Herrera's books. And she's got Ending Male Pelvic Pain, The Ultimate Self-Help Guide for Men Suffering with Prostatitis, Living with Pelvic or Sexual Pain. And again, all the imagery and pictures here are guys, I mean, so this is really written from the men's perspective, male anatomy. Or for women, you can get the Ending Female Pelvic Pain book. So as an example, she talks about how to use a TENS unit and where to put the pads for the TENS unit. And talks about how to use a wand if you're doing internal pelvic floor work. And then if you're pregnant, she even has a book, Ending Pain in Pregnancy, that's related to muscle work. So, again, don't be passive when you go to any medical care provider. Man, you guys are equals. Don't put that doctor or that physical therapist up on a pedestal. You are equal. You're paying him or her. They're not paying you. You ultimately are directing your medical care. And for you to direct your medical care really correctly, you got to understand where they're working. And that means you got to refresh your anatomy just a little bit so you really understand it. Okay. And Joe, hey, listen, ask your mom. Ask your mom if she's still with us, or your dad, if they can remember any trauma. You played football. You took a lot of pelvic stuff when you played football. That could easily have set the foundation for all of this. And the other thing would be when you work with a physical therapist, ask them why the muscles get tight again. Because for some of you, you do physical therapy, it relaxes your muscles, but it comes right back a week later. Why? And that's usually because there is a structure outside of the bladder that's stressing the muscles, usually the bones. And so again, we want to look at, did you sustain a hip injury or an SI injury or a knee injury or a foot injury? Or are you just pigeon-toed or duck-footed? That can also be part of the issue too. So Patty says, I've been doing pelvic floor physical therapy. In my last session, my therapist said she could tell there was less tension. Also got the results of my vaginal ultrasound, and there's some notes that I think might be clues. Okay, interesting. Anne says, you had a bad flare after using estrogen cream. Anne, if you are super dry and you used it topically or vaginally, it's going to burn like hell at first because your skin is dry. Your skin doesn't have the defenses to protect itself. And so it's normal for women to experience more pain at first when you put estrogen cream on. But what happens is your skin immediately starts to use that estrogen and will start to produce mucus. And what you should notice is the heat gets better every subsequent time. For me, it took about 2 weeks before the heat went away. When I first started using estrogen cream, it burned for about 30 minutes. Now it's like a puff of warm air, super short. But if I forget to use my estrogen cream for 2 weeks, the heat comes back. So a lot of women, tragically, they have that heat reaction, they have that pain reaction, and they never do it again. And they don't understand what's going to happen. What's going to happen is that skin is just going to get drier and drier and drier and drier. And then you're really in serious skin problems and urinary tract problems because of that. Ravonda says, can a calcium citrate supplement possibly cause a flare due to citric acid? Not usually, no. And I don't believe calcium citrate has citric acid in it. The citrate is a different molecular structure. I might be wrong, but I don't think so. Amanda says, I wanted to tell you when I got the nerve block, they asked me if I'd fallen on my tailbone. My ligament is bent. I remember you talking about the injury to the tailbone last week. I fell when I was 14. And I fell and broke off the tip of my tailbone in junior high. Those tailbone injuries are wicked. The long-term consequences from tailbone injuries, especially if if the bone is bent and or the ligament is bent and it's putting weird stress. And let me show you. I want to show you exactly why. Okay. So look at this. This is your sacrum. So like here's your hip bones. Obviously these are your vertebrae. And your sacrum is a triangular bone that basically attaches your hip bones to your spine, right? I mean, this is critical to you standing up is you have to, we need your hip bones to attach to the center of your body. And your SI joint obviously is right here. See, the SI joint's right here. Okay, so then on the sacrum, there's 4 holes in it, and the nerves come from the spinal cord and go down through these nerves, and they emerge inside the pelvic cavity. And this is where they get compressed by muscles. But let's look at the tailbone here. Here's your tailbone, right? So look at the attachments. So we have attachments, we have ligaments, we have muscles. If this tailbone is crooked, and also look at it this way, your tailbone curves under like this. So if your tailbone is straight or pushed outwards, see, imagine what that would be like. Imagine how bad that would feel. Or if your tailbone has healed to the left or to the right. Tailbone injuries are just really wicked. And there's a long-term toll to tailbones that have healed out of position. So again, man, we are seeing now that we know to ask, we are seeing so many tailbone injuries in patients with IC and pelvic pain. Carla says, I had endometriosis for 30 years. I was diagnosed with chronic IC in June when I had my hysterectomy. Thus far, I'm following a low acid diet and using a heating pad, taking it one day at a time. So, the hysterectomy itself is pretty traumatic. So you're going to have some muscle issues. Hun, you got to understand that the challenge with endometriosis here, hold on, I'm not comfortable here. The challenge with endo is that obviously uterine tissue can migrate into different parts of the pelvis where it becomes, and it starts to entrap things. It can wrap around your bladder. It can wrap around your urethra. It can wrap around your bowel. It can even move up into your belly. And unfortunately, when you have your period, when those hormones change, not only does your normal endometrial tissue bleed, but so does the endometrial tissue in your belly, and that hurts badly. Your blood is supposed to be in blood vessels. Blood is not supposed to be floating through your belly. When it floats through your belly, it hurts like hell. And that's one of the reasons why endometriosis is so incredibly painful. The long-term toll of that is that you were in pain, so your muscles got tight in a guarding reflex. And so the odds are your muscles have been quite tight for some time. Plus, we have to throw in any endometrial adhesions that you might have had. And now we also have to deal with the fact that you've had a major surgical trauma with the hysterectomy. And recovering from that hysterectomy might be a bit more challenging. It took me a year to get over my hysterectomy, and I still occasionally have issues from it. And it's been 3 years. So there you go. So again, for you with the endo, I mean, the good news is that you're not going to have the estrogen necessarily to push the endometrial tissue to bleed more, but it's complex. It's going to be a bit of a complex recovery. Julie says, I injured my tailbone in elementary school, but didn't have a problem until my mid-40s. Could they be connected? 100% they are connected. 100% they are connected. You always thought yours was an autoimmune disease? Mm-mm. Mechanical issue with that pelvic pain. Patricia said, could it be that there's more than one problem? I've been diagnosed with pelvic floor myalgia. We'll begin pelvic floor therapy this week. I had cystoscopy where my bladder and urethra look perfect. However, if I drink wine, I will pee several times during the night. All right. So let's talk about this. Patricia, you have to get this book. It will help you understand. So there are two, I call the bladder, the relationship between the bladder and the pelvic floor, the chicken versus the egg dilemma. Which comes first, the chicken or the egg? And for us, it's which comes first, the bladder or the pelvic floor? They're both involved. They cannot not both be involved because they're so fundamentally connected to each other. So for some of you, IC begins with a bladder injury like chemo, and your muscles get tight to protect you. And so therapeutically, our therapeutic priority is to calm the bladder, soothe the bladder from the chemo, knowing that the muscles were released. But if your symptoms began after a muscle injury, of course, you have no clue you have a muscle injury. You have frequency urgency. You call the doctor. You say, hey, I got an infection. Doctor gives you antibiotics. They don't work. The doctor goes, hey, maybe you got overactive bladder. They give you overactive bladder meds. They don't work. Doctor looks in your bladder. Well, your bladder looks pretty good. I don't see anything wrong with your bladder. So maybe you've got IC, this terrible incurable disease. Maybe you need to take Elmeron. They don't work. You could be on bladder therapies for a decade. They wouldn't work because if your symptoms began after a pelvic floor injury, our fundamental priority is to restore muscle tone and blood flow. The consequences of tight muscles are profound. It reduces blood flow to the bladder. It's very hard for the bladder to be healthy if it doesn't have good blood supply. And it's almost impossible for the nerves to be healthy if they don't have good blood supply. Scientifically, we call this the somatovisceral reflex. Can muscles influence organ behavior? And the answer is yes. That if you have tight muscles, that is eventually going to damage the bladder. And that would explain why you have bladder sensitivity now. But it's always about the chicken versus the egg, which comes first. And that's the challenge here. That's the challenge for every patient is we have to try to figure out what the fundamental problem, what the fundamental insult was first. Because we have to focus on that. If the fundamental insult is some sort of muscle trauma, we have to work on that. Otherwise, you could be on Elmeron for decades and never, ever get better. Carla says, my legs are 2 different lengths. Yep, we see that often. Carolyn has TMJ. Yep, that's a chronic overlapping pain condition. Judy says, should we not use estrogen? No, you should use estrogen cream because that will help improve your skin quality. Unless you have a worry about cancer, oral estrogen would be something to have a really good discussion with your doctor about, but topical estrogen is considered much safer and not associated with a greater cancer risk to any great degree. Google it, safety of topical estrogens. I gotta drink my Gatorade. I drink really diluted Gatorade because I'm dealing with a little low potassium issue from the stress of life in California. Yes, and you can have multiple subtypes. Angela says, 5 years now, and your website, diet list, and form helped me so much when I had no idea what was going on. I'm so glad, hon. Form's pretty quiet these days, but that's okay. We have other work to do too, massive work. Pamela says, I fell out of my car. I fell out of a car on my butt when I was younger also. Yes. Often wondered if that had something to do with it. I believe it did, yes. Karen says, I now have retention. Seems to be caused by new underwear and chemicals like new material in pants, blankets, extra near my urethra. You know, Bev Lauman wrote a blog on that on our website. You can find that on our website. It's absolutely true. There are some fabrics and or laundry detergents that will absolutely trigger chemical irritation of the urethra and the bladder. She had a hysterical blog on it. I should find it. Just go over to, I think it was something like the case of the painful underwear. Well, it's somewhere on our website. Okay, so we're now going to move into a different portion of our meeting, and that is we're going to start the Zoom portion of our meeting. So with Zoom, you can come into the room and describe your symptoms, and I will see if I can help you. We had a huge Zoom meeting last weekend. It was awesome. If nobody comes in, that's fine. That's because I got other fish to fry too. But if y'all want to come in and ask questions, I'm happy to do that. It is going to remain live on Facebook and YouTube. You guys will not be able to see my computer screen, but you will be able to see my face and hear the discussion. And then I will come back to Facebook and YouTube. All right, so hold on a sec. I'm surprised I've kind of lasted this long because I've had this sinus headache for a couple of days. We'll see. So let me just start this Zoom meeting, and then I will post the link. Alrighty, the Zoom meeting is up. I look absolutely terrible. Life. Life, 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 life. All right, so I'm going to paste this link into YouTube and Facebook. I don't think we're going to go very much longer today, other than Zoom. Just fair warning. I got to get to this book, and honestly, I also need to relax. Also, Mondays are my day off, so don't bother calling me tomorrow. If you want to talk, you need to wait until Tuesday. You know why? Because I'm a gamer. And Mondays are always my day off, but tomorrow's really exciting because Shadowlands is out on World of Warcraft. Oh, wait, I don't want to end this. I want to, hold on. I'm going to be playing World of Warcraft tomorrow. No shame, baby. If you deal every day with bladders, one of the best ways to cope is to play computer games and shoot things. That's one of my emotional strategies here. All right, so y'all both have the links on YouTube and on Facebook. Let's give it a couple minutes. If people want to come in, that's fine. If not, that's okay too. I got no sweat in this. All right, time for a potty break. Go use the restroom. Be right back. If you're coming into Zoom, I will. Okay, the Karen's come in. I will let you in one at a time. Hi, Karen. Karen, if you just hold tight for a moment, I will be right back. Alrighty. Hello, Laura. So whenever I need to relax my brain, I turn on Kenny Loggins. And right now, the song which is working for me is The River Run. Further and further, the things that we've done, leaving it one by one. And it goes on and on, watching the river run, listening and learning and yearning, listening and learning and yearning, run river. I love that song. Deep breath. All right, my friends. So let us go. Oh, here Pamela says, I had chemo radiation in 2018. Noticed my symptoms got worse. Yeah, because the chemo is going to irritate the bladder wall, and the radiation cystitis, and radiation can be a little bit damaging to some of the blood vessels in the bladder wall and cause some symptoms there too. And so it should come as no surprise that you've had some symptoms after chemo and radiation. And hopefully and guys, for anybody who is going to be facing chemo, not all chemotherapy will damage the bladder, but for those that will, they can give you a medication that will stop that. It will prevent it from happening. So, all right, we're going to go to Karen first. Hello, Karen. How are you today?
I can't believe I ran into this just on the fly. I didn't really know this was happening, but I'm having some severe problems with can't even use soap on my hands, because even though I wash my hands like about 4 or 5 times after I use the soap on my hands, when I wipe, I get retention. I mean, anything, new pants, new underwear, blankets, they don't have, I can have my pajamas on, and if they're new blankets, they cause retention. I mean, I'm really having a really rough time with this. It started out to cause retention. Before, it used to cause burning, frequent urination, and all that. I've had it for 8 years.
Okay.
Now it's causing retention.
So we have to think about mechanisms of action here. So clothing itself is not going to cause your muscles to get tight, but clothing and dyes on clothing are certainly have the potential of irritating nerves. And I wanted to see if I could find this blog. I think it was the case of the poison underwear. I think that's, let me see if I can find that. The case of it was a great blog that Bev Lamon wrote exactly on this very topic. I know for me, I can't put anything on that is not washed first. Everything has to be sometimes 2 or 3 times to get all the chemicals out.
I can't use laundry detergent. I can only wash with plain water. So my life is really, really difficult.
Hey,
right now.
I have an idea though. And you know what? If you want to try it, I'll send it to you free.
Okay.
Have you ever heard of this? Echo egg?
No.
Okay, so Echo, I'm going to open it.
I'm bad with fragrance also.
There's no fragrance in this. This is a different way of doing your laundry that uses minerals. Whoops.
Okay.
And so it is a plastic egg, or it's not plastic, it's silicone. And you end up putting a bag of minerals in it, and there's black ones and white ones, and it was developed in England for people who have extreme skin sensitivity and psoriasis who couldn't tolerate any chemicals. And so it's certified by their it's fragrance free, does not contain any chemicals or perfumes, is gentle on your skin. I have used this. I have one.
Thank you.
Yeah. So if you want to email me, icnetwork@mac.com. Anybody else out there? Because I've had these in my store, but I've never really talked about them. If anybody wants to try an Echo egg, email me your mailing address, icnetwork@mac.com, and I'll send 3
Is
or
that
4.
Matt, M-A-T?
No, Mac with a C, for short for
MAC.
Macintosh computer. Okay. If anybody wants to try this, I'm more than happy to send a couple out and give it a shot and see what you think.
Thank you.
So
How
Echo
about
Egg.
hand soap? How about hand soap?
I
Having
use.
problems with any kind of hand soap.
What about Basis? Have you tried Basis soap for?
Yeah,
Really?
I'm actually having more problems with a regular soap than a detergent soap. I found a detergent soap, but of course they took it off the market that I was able to use for a little while. But now I haven't been able to. I'm just telling you, I don't know how that could possibly affect me just by wiping after I wash the stuff off my hands, and that it irritates me and burns me down there. How sensitive I must be. I don't know.
Well, I mean, it shows you've got extreme central sensitization. Hold on. See? I tell you, it's not a support group meeting if something doesn't fall. My office is always a wreck after we do these meetings. So this new book that we're writing is actually the second edition of this book called The Proactive Patient, and I'm now an author of it because I'm doing most of the updating. And it was written by Gay Sandler. And Gay Sandler, she also wrote Patient to Patient Managing IC-Related Conditions, which was kind of our self-help Bible 20 years ago. She's the one who dove into chemical sensitivity. And I just re-edited all of her stuff, like literally in the last month on this. I wanted to see what she said about, let me just see. Well, duh, I'm going to look at that one. Let me just look at this is the text of it right here. Let me just see if I can get to that. Let me just, I don't remember. Chemical sensitivity, here it is. At least 30% of the American population have multiple chemical sensitivity, strong physical reactions to a wide variety of chemicals and irritating substances ranging from mild to severe, including to even low levels of chemicals. Physical symptoms, headaches, hacking coughs, bronchitis, dizziness, tremors, swelling, allergic conjunctivitis, dermatitis, fatigue, cardiac, muscle pain, numbness, flu-like symptoms, and reactions can cause genitourinary symptoms. I think your classic multiple chemical sensitivity disorder. I do.
Oh,
I do. And so if you can just, so here's what she says about personal care products. Most scented, let's see, most scented products today are petrochemical neurotoxins. 95% of the chemicals in fragrances are synthetic compounds derived from petroleum. The content of these fragrances has been found to be capable, yada, yada, yada. You all know this. And they talk about cosmetics. So a website that she and I recommended is the Environmental Working Group, EWG.org. And EWG.org has a database called the Skin Deep Database, which, so E for environmental, W for working, G for George.org. You go over to their website and go to their Skin Deep Database, and that will rate the soaps that you're using based upon safety. And I think that that's going to be the best place for you to go to try to figure out what you're sensitive to.
thank you so much. It is so helpful.
It's so weird.
I so appreciate it.
I know, but it's so when you're sensitive like this, see, you guys, you got to understand that sensitivity is nerve driven, and what is what is nothing to somebody else is agony for somebody who's sensitive. You know, Windex in my oven is agony for me. It's just it, and so it's hard when you've got sensitivity and other people don't quite get it. But I think the Skin Deep database will help you. Okay.
Thank you.
Okay. All right. And guys, let me just also say here too, we really see this with blue jeans. Anybody who goes and you buy a pair of blue jeans, you have to understand those blue dyes can be very toxic. Doesn't matter if they're in jeans or cotton or shirts. You have to be really careful with anything that's dyed blue from China or from Asia. You always have to wash those 2 or 3 times. You got to try to get as many of those blue chemicals out. The minute you feel any irritation, take them off and wash again. It's the blue dyes are just toxic. Same is true for toilet paper, Kleenex, underwear. You want to stay away from blue underwear, but you know, pink underwear should be fine, or white underwear like that. Okay. All right, hun. All right, let us go to Laura. Hello, Laura. Can you unmute yourself?
Yeah, so I have pretty much just a quick question.
Okay, I need you, before you ask that question, your voice is very, very faint.
Yeah, is that better?
Much.
Okay. Yeah, so I kind of have a combination subtypes of neurosensitivity and muscular, and now I know that my one leg being longer and my tailbone injury when I was in my late teens
Okay.
have probably not helped.
Yeah.
I have had physical therapy in the past, and whenever I do again, I will be going over those issues, definitely. My particular question, my problem I've been having right now is that I started using an estriol cream a few weeks ago for the first time.
Okay.
And I've been having flares ever since. And I have been, essentially kind of, you could say, in remission or whatever. I can really control things with my diet, and typically don't have flares. So yeah, I'm just wondering how long might that last? Should I stick it out?
Well, so when you say you're having a flare, is it as soon as you put so number one, is it oral or topical?
Topical.
Okay. Does it happen as soon as you put it on that you feel discomfort?
No, it's like my typical pattern of, the next morning, throughout that day, and then in multiple days. It doesn't even have to be a day after I've used it either. It's just, if you look at that 3-week time period, I'm having flares more often.
Are they bladder flares or pelvic floor flares?
So that's a good question. When you were talking about this today, I've always considered them bladder flares, but they're probably more pelvic floor flares.
Okay. Yeah. Can you describe the symptoms? What are the symptoms like?
It's an aching, burning feeling. There is a bit of relief after I pee, but there's still a residual pain that, I have all the time.
Where is the pain that you have all the time?
That's a good question. I've been educated on all the muscles and everything. I've always associated it mostly with the urethra.
Okay.
So,
okay.
Yeah.
Okay. How old are you? If you don't mind me asking.
Oh yeah. No, I'm 59, 6 years past.
Girl, we look like we could be sisters, to be quite honest. Don't you think?
We've talked on the phone before.
I know, and we just like you're a redhead, I'm a redhead. We look so similar. Yeah. Okay, so the urethral. How long have you had the urethral pain?
Since my late 20s.
Really?
Oh yeah.
And did they make a diagnosis, a urethral diagnosis? Did they have urethritis or urethral syndrome?
No, at the time back then, it was just, I was on a low oxalate diet. I wasn't diagnosed with IC. It was, I forgot the vulvar.
Was
the
it
vulvar
vulvodynia?
pain.
Did they diagnose you with
Yes,
vulvodynia?
yes,
Okay.
yes, yeah.
Okay.
Mhm.
So when we
And then I've been diagnosed with IC much more recently. I used to see Dr. Christopher Payne down in San Jose for a while, but I haven't been to see him in several
Okay.
years now.
Okay.
And yeah, my OBGYN diagnosed me probably about 10, 12 years ago. Mhm.
Okay. So the urethral pain started in your 20s.
Yes.
So take me back in time to your 20s. What was happening in your life back then? Had you had babies? Had you?
Yeah, no, I didn't have children until my mid to late 30s. But, I guess, so I had been bisexually active for probably about 5 years, or 5 to 7 years by the time it started. And it was preceded by a couple of years of fibromyalgia.
Oh, okay. And do you remember?
It went away.
Okay, so the vulvodynia did go away.
No, the fibromyalgia.
The fibro went away.
Yeah, and then ever since I've had, yeah.
Do you still have vulvar symptoms, or is it just urethral symptoms?
No, not very often. That's pretty rare.
Okay, when you had vulvodynia, was it your perineum that was on the fire the most? That bundle of skin between your vagina and rectum?
Yes. Mm-hmm.
Okay. So have you had a pelvic? Well, listen, you saw Chris Payne.
Yeah.
Oops, hold on. I dropped something. Dropped my elevators. So Chris had to have done a pelvic floor assessment. What did he say was going on with your pelvic floor?
Tight.
Okay. Okay.
Yeah.
And did you do pelvic floor physical therapy?
Yes, I did.
And
that's been several years.
Did the pelvic floor physical therapy help you?
To some degree. I'm trying to remember exactly what was driving the therapy. I think for insurance sake, we were saying it was for incontinence because the pain on intercourse, my insurance company would not cover. And so then I stopped doing it.
Okay.
It was like $250 a pop.
Okay. Let me ask you this. Did you always dread going to the urogynecologist because you knew putting the speculum in would hurt?
I guess, that was probably in the back of my mind, but not horribly, I guess.
Were you an athlete when you were younger?
No.
And you remember any trauma at all when you were younger?
The only trauma now that, what you're saying today was my tailbone, which I had never put these two together. When I was 18, we went on a 9-hour car drive and I was slouched. And and then ever since then, that hurts.
Okay. I want to write a book on the tailbone at this point in time. It's so amazing the number of you who have tailbone issues. So, one of the things that Dr. Weiss talks about in his book, Breaking Through Chronic Pelvic Pain, and one of the mysteries is, why does pelvic tension come back? You go to physical therapy, your muscles respond beautifully to therapy, and then a couple days later, a week later, 2 weeks later, whatever, you've got exactly the same trigger points in exactly the same location in exactly that same muscle group. Why? And understanding the mechanical influences on your pelvis is important. But one of the other things that he talks about, now remember, vulvodynia, they now believe, is caused to a great extent by tight pelvic floor muscles. And so when I asked you the question, was it your perineum that was on fire like mine? And the answer was Yes, it was the perineum, the perineum that's on fire. So let me hold up something here. Hold on a sec. I want to. Let's see. I want to do this the right way. I want to make this easy. Okay. So I'm going to hold. Oops. I'm going to hold up a picture here. Let's see. I don't know. I don't know if I can get right in there. Okay.
Yeah, got it.
Okay. So these are the levator ani muscles, right?
Yeah.
And so here's. Let's see. Hold on. So here's the tailbone. Here's the rectum. Here's the vagina. And look, right in between there is something called the perineal body. And what's cool about this picture is you can see the muscles that attach directly to the perineal body. And he points out that the reason why women often have severe perineal pain is not from their skin, it's from a tight muscle immediately above their perineum. And so I think you need to revisit your muscles. Number one, we have to and just because you can, you think that the estradiol cream is triggering flares, but you think they're muscle flares. And so is there the possibility that you're just having more muscle flares, maybe from stress, because right now we all have reason to be stressful, especially in the last month.
Yep.
I will say though that, and this would be a very interesting question for Dr. Payne. I have always believed that there's a hidden hormone subtype. That there are some people who are just remarkably responsive to fluctuations in hormones. I don't. So some people flare when they get too much estrogen. Some people flare when they get too much progesterone. So there's a chance that that might be in your group too. I don't.
Yeah. So that's quite possible. So I'm also taking something orally, but it's called pregnenolone. And my regular doctor had prescribed, or my holistic doctor, Dr. Cantwell. So he has prescribed the pregnenolone to start up testosterone for energy and cognitive functioning and such. But my OB/GYN regular one I went to last week, pointed out, and I've been afraid of this too, is that the next line of production is estrogen also, and I need to be aware, that this could be causing me other issues. But I've been on it for several months, and the bladder stuff just started the pain.
The urethral pain. Let's be specific.
The urethral pain began 3 weeks ago, about the same time as I started the estriol cream. So, yeah.
Are you rubbing the cream into the entrance of your urethra?
No, I'm just using the applicator for insertion. Yeah.
Have you changed laundry detergents?
No.
I have a blog on our website, The 7 Causes of Urethral Pain. Come on over and take a look at that and see if there might be something else that triggers. Sometimes there is some patients can get an infection of the periurethral gland, which is halfway up the urethra. But you can figure that out yourself by just inserting your finger in your vagina about an inch and touch along the front side. And if you feel what feels like a deep pimple that's painful, then you could have an infection in that gland. I think you're going to be like me, hun. And maybe it's just maybe instead of, okay, so we're missing one thing. Is it a compounded estriol or is it a preservative free?
Yeah, I don't know. It's from Koshland Farm in San Francisco, and I just don't know. I need to call him and get the details.
Why did you call him? Maybe there's something in the base that's irritating you. That's possible.
Yeah. Yeah.
I get my compounded cream. I use an estradiol cream from the Women's International Pharmacy down in Arizona. They're a mail order pharmacy, and they're really quite good. And they will work very, very closely with people who have sensitivity to creams and bases.
Yeah. Okay.
Okay. All right, hon. Well, good luck. But I
thank
think you need to go back to your pelvic floor and just check in with that and see what's going on with that. And make sure you tell them that you had a tailbone injury. Okay.
Yeah.
Okay.
Thank you. I appreciate
All right,
your
hon.
help.
Nice talking with you.
Okay. Yep, you too.
All right, Judy, I can't see your face. But let's see if Judy, are you there? Hello, Judy. You have to, if you're there, you have to unmute yourself. I can't unmute you for some reason. Let's give Judy a minute. Hold on, let me type in the chat window here. Judy, are you there? All right, I'm going to come back to Facebook here for a moment. Let's see. Jacqueline says, haven't been here in a while. I'm sensitive to just about everything, including medicine. Girl, me too. Laura says, John Lee, I know it's not John. I know it's his wife. I just zone on your name. I'm sorry. Suggest trying a different base for your estrogen. We can be sensitive to the base use. That is so incredibly true. Krista says urethra, same symptoms as me. Generally, when we see urethral irritation, usually, the urethra is kind of like the canary in the coal mine when it comes to estrogen atrophy. So it's the first part of your urinary tract to start screaming when your estrogen levels start dropping to a certain point, and it will feel like there's a drop of urine stuck in your urethra that won't come out. And your urethra gets very, 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 very irritated. And so if your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder. And that's when we want to look at a topical estrogen to give that tissue some mucus so that it can defend itself. All right, last call for Judy. Okay, I'm going to shut down the Zoom meeting. Thank you, you guys. Thank you.
Thank you.
All righty then. Zoom meeting is shut down. We are now back on Facebook and YouTube. The other things that we're going to look at for urethral pain is, number one, we're going to look at the quality and health of your skin. The second thing we're going to look at is possible chemical irritation. So we're going to look at mini pads. Are you wearing a mini pad? We're going to look, because especially the super thin mini pads will release very irritating chemicals. We're going to look at laundry detergent, fabric softener, soaps. You should not be using any fabric softener at all. Laundry detergent, the laundry detergent I recommend is 7th generation, or if you wanted to try that mineral egg thing, Echo Egg, that would be very, very interesting. Obviously, no douches, no chemicals. Listen, there's a whole billion-dollar industry that's invested in telling women they're dirty down there. You're not dirty down there. The cleanest organ in the human body is the female vagina because it sloughs off cells every 4 hours. And so you don't need to be quote unquote clean. You're already clean. Don't give them the satisfaction. Krista says, you always end up with pyelonephritis? That's odd. So the urethra, obviously, one of the other things we're going to look at is infection. Is there any chance this patient has active urinary tract infection? Because often it's a urethra that was screamed during a UTI. The fact that you get nephritis afterwards speaks to potential infection. Remember that the urethra is physically short. It's only about this long. And as a consequence, during sex, it's very easy to push bacteria up in there as compared to a male urethra, which is about this long. And so we want to rule out infection. We want to rule out a periurethral gland infection. So again, come on over to our website, icnetwork.org, and check out article, The 7 Causes of Urethral Pain. Robin says she has urethral pain all the time. Okay, so Robin, tell us, when did that start and how old are you? Krista says no bacteria ever grows. So Krista, this would be a good time for you to have a next generation urine test because a typical urine culture will only grow out bacteria that will eat that medium. You know, there's a growth medium that has certain nutrients in it, and there's lots of different bacteria that eat lots of different types of things. And so the urine culture is limited to a certain degree by what growth medium is used. And the fact that this is persisting for such a long time and you've had pyelonephritis, to me, that would be time to have a next generation urine test because it doesn't grow anything. It looks for bacteria, it looks for DNA in your urine, and it will tell you good bacteria, bad bacteria, and fungi. And this would be meaningful data to either rule it in or rule it out. Okay, so if I were you, I think that this would be very interesting data. So Robin said, Robin has severe urethral pain. She's 51. She started 4 years ago, but you've had IC friends. You've had IC for 30 years. So, Robin, the fact that your symptoms started in your late 40s really points to 2 things: estrogen atrophy or tight pelvic floor muscles. So, are you it would be very, very important to have a doctor look at the quality and health of your skin. Because if your vulva is dry and your vagina is dry, then so is your urethra and so is your bladder. And there is a very easy fix for that. And it is a topical estrogen product that is generally, they would have you rub a pea-sized drop of it right into the entrance of your urethra. See, that happened to me when I was 51. I can't believe, I mean, in my brain, I'm 25, so it's so weird to be older, just so weird. But I started having this feeling like there was a drop of urine stuck in my urethra that would not come out. And it was super, super irritated. It was driving me crazy. And, you know, guys, listen, my IC self skills are really good. I mean, obviously, I wrote the IC network. And I know my stuff. So for this urethral pain, I threw everything I knew at this urethral pain, trying to get it to calm down. And 3 months later, I was just like, none of it makes sense. So I went to my urologist. And so the first thing he did is a sonogram to see if I was emptying my bladder. And I was emptying my bladder. Even though it felt like there was something stuck, I was emptying my bladder. So there I'm laying on my back, you know, in the stirrups, knees apart. He takes one, I'm laying there and he goes, Jill. I like look up at him and go, what? What'd I do? What did I do? And he goes, didn't you use the estrogen cream I prescribed for you last year? And I went, no. And he goes, why? And I said, because in my brain, I'm 25 years old and I can't imagine having anything age related, which is true. And he said, I wouldn't have prescribed it for you if I weren't seeing it happening, hon. And then he explained that the bottom half of the urethra is remarkably sensitive to the loss of estrogen. And you get a lot of urethral irritation as well as feeling like there's a drop of urine stuck in there. And so he prescribed estrogen for me again. I then went to my gynecologist the next day. He absolutely confirmed it. And he had me rub a pea-sized drop right into the entrance of my urethra. It took about 10 days for it to go away. And so it was completely skin driven for me. And again, Robin, the other thing I would really want to know is what's going on with your pelvic floor, you know, because if your pelvic floor muscles are tight, then that also your levator ani muscles wrap right around your urethra. And so if your levator, see, so here's your levator ani muscles, right? And so this is a part that attaches to your pubic bone. This is a part that attaches to your tailbone, right in that area. And so you can see that if these muscles are tight, they're going to start squeezing the urethra. And so we always have to rule out muscle tension. And it's not about getting a hormone panel. It's about somebody looking at your skin. There's a hallmark signs that they look for, specifically some weird funky lines that happen as the skin gets drier. So it's not, a blood test is interesting, but it's not as meaningful as just getting somebody to look at your skin down there. Becky said, has anybody had a neuromodulator implanted for IC and vulvodynia? Becky, what kind? Are they considering a interstem pudendal nerve neuromodulation, or what kind of neuromodulation do they want to do? Krista says, I've had problems. Oh, here, hold on a second. All right, you're done. Krista said, I've had issues since puberty, diagnosed with IC when I was 25. I'm 37 now. So Krista, again, we do something called subtyping. And so there are two things that we would look for with somebody whose symptoms began at puberty. Number one, did you sustain an injury? Did you fall on your tailbone? The puberty might have nothing to do with it. It literally could be physical trauma. Or could it be hormone driven? Could you be one of those patients who is a little bit more hormone sensitive than others? So go back in time and think about when your symptoms began and did you suffer any trauma? Shannon says, what can you do when pain happens due to stress? Well, we have to try to figure out, you can have a bladder wall flare or a pelvic floor flare under stress. You can have either one of them. And so if it's a pelvic floor flare, you have to do things that relax muscles. So we have, if you go to the IC Network website and you sign up for our free newsletter, which I haven't sent one out in 5 months right now, 4 months, I'm way behind. You can download for free our 40-page flare management guide, and it has hour by hour rescue plans on what to do. So if it's a pelvic floor flare, then what you're going to be doing is focusing on relaxing muscles. So using heat would be the first thing, taking a hot bath, taking a hot shower, maybe doing a guided relaxation to try to relax tight muscles, or maybe using a muscle relaxant, like baclofen or Flexeril or vaginal Valium suppository. If it's a bladder wall flare, then what we've got to do, let's say the bladder wall flare was exacerbated by something that you ate, then we want to increase your water to try to dilute your urine a little bit more, not massively, you maybe try alkalinizing your urine with a little bit of Pre-Leaf. Pre-Leaf is the sponsor for these meetings, and it's a calcium glycerophosphate, and it will reduce the acid in your urine and reduce the acid, any residual acid from foods that you're eating. And so you can do this, especially before a meal. A great product, been out for years. Of course, the one thing I always say is you never eat this like candy because it is calcium, and the calcium's going to go somewhere. And if you start eating a lot of it, you could throw kidney stones. So follow the manufacturer's recommendations. It's like Tums, okay? So you could alkalinize your urine. You could do azo bladder pain relief tablets, which I have right here. So this can help to numb your bladder wall. And you can get this in any store. It's pyradium. It's the stuff that turns your urine orange. And you may need to ride it out. You may have to ride that out. Again, use a little bit of heat to prevent your muscles from getting tight. If the flare worsens, you can ask the doctor for a rescue installation, and which would numb your bladder wall and calm those nerves in your bladder wall. And these are the moments when using a little bit of Norco, if you happen to have it, is particularly helpful. Just a quarter of a Norco or a half of a Norco might early on, before the pain gets set. Guys, don't wait until you're crying before you use your pain meds. You got to catch it early. If you catch it early, it will take less medication to turn it off. But if you wait until you're sobbing, you're letting the nervous system get amped up, and it's going to take a lot more pain medicine to turn that pain off. So a little tiny bit of Norco, if you happen to have it early on, if your doctor's told you it's okay for you to do that, would be reasonable with a bladder wall flare. All righty. But again, going over to our website, sign up for our newsletter, and you can get our free flare management guide, which I have to rewrite. I got so much stuff to rewrite. It's ridiculous. How do I find out about, Robin says, how do I find out about your pelvic floor muscles? Go to your gynecologist and just ask them to do a pelvic floor exam. It'll take 30 seconds. They'll just glove up, stick a finger in there. If they're tight, they send you to a pelvic floor physical therapist to do a proper diagnostic workup, which takes about 45 minutes to an hour to do. Becky says, bladder on a certain nerve to help with IC. Possibly see if it would help with vulvodynia. 6th nerve, possibly, I think interstem. So Becky, listen, neuromodulation is number one, it's a step 4 treatment option in the American Urology Association guidelines. The IC guidelines have 6 steps of treatment, and they're arranged with respect to the risk of adverse event. So they want you to start with the easy, non-invasive stuff first. So step 1 is going to be the self-help, diet, progressive relaxation, stuff like that, supplements, stuff like that. Step 2 is going to be oral medications, bladder installations, and physical therapy. Step 3 is going to be Hunter's lesion treatment primarily. Step 4 is neuromodulation or Botox. There are 2 different forms of neuromodulation. There's neuromodulation that requires surgery by the sacrum or on the pudendal nerve. That's known as interstem. Or the neuromodulation that's done at the ankle. It's actually called post-tibial nerve. And the name of that is called urgent PC. There are huge differences between the 2. Interstem requires at least 2 surgeries, maybe 3 or more. There are thousands of serious adverse events reported to the FDA with interstem, a lot of deep tissue MRSA infections. We've had patients who have gotten gangrene from it, and there are fatalities. The last time I counted, which was several years ago, there were 20 fatalities associated with interstem. And I remember one case in particular where somebody's heart started beating in time with the interstem. And there was a doctor who filed a report in the FDA mod database that he believed that it should be pulled from the market because they had not solved the problem of the frequent deep tissue MRSA infections that were happening. So interstem was created at UC San Francisco. Now, I'm north of San Francisco, about 80 miles, and I actually was a support group leader when interstem was developed. And so I had tons of those early interstem patients in my support group. And let me tell you, it was ugly. Back then, they weren't using anesthesia to do trials. These patients were screaming bloody murder in the doctor's office as they were sticking needles in their back with no anesthesia. But the devices moved and et cetera. There were just lots of issues with interstem back then. Another doctor at UC San Francisco was so appalled by what he was seeing with interstem that he said, hey guys, you don't have to operate down there. You can hit the exact same nerve at the ankle. And you can hit the nerve with an acupuncture needle. You don't even need to do an incision. And Dr. Marshall Stoller, Stoller, and he is the guy who invented post-tibial nerve stimulation, now known as urgent PC. And again, he did it because he was so appalled by what these patients were going through with interstem. They're both Medicare approved, and yet the differences are nothing short of astonishing. The last time I looked for urgent PC, there were 2 adverse events reports for tingling as compared with thousands of adverse event reports for InterStim. It is something that you do it 10 times or 12 times at the doctor's office. And you'll know, I mean, I fell into this group because I got referred to UC San Francisco, and I'm forever grateful that I landed in Dr. Soller's office instead of Dr. Schmidt's office. Because in Dr. Soller's office, they empowered you. I mean, they taught me how to do it at home. I had my first 2 hours without pain at week 3. I had my first day without pain at week 7 doing urgent PC. I believe that urgent PC broke me out of a wicked flare that I'd had for a year. Cost is a matter. The cost of the post-tibial nerve stimulation is a fraction of the cost of InterStim. And I think one of the things that, well, there are 2 things that really bother me about InterStim. Number one, you have a trial, and if the trial is successful, they will implant the device. What we have consistently seen in a small group of patients is that when people wake up from the permanent implant, they can tell there's a problem. It feels different. And when they tell the doctor there's a problem, the doctor goes, "Oh, it's just post-op recovery. Don't worry about it. You just," or what they'll do is, "We just have to reprogram the device." And so for 6 weeks, a couple of months, the patient has this device. They know it's malfunctioning. They know there's a problem, but the doctor doesn't believe them. Or they call the InterStim rep, and the InterStim rep gets involved and tries to placate the patient. And the patient is going, "Guys, there's a problem. It's not right." If InterStim hurts, like we had one patient who every time she had a bowel movement, it shocked her. And her doctor told her that was normal. She called me and I went, "Hell no, that's not normal." And we got her connected up with the company, and the company said, "Yes, no, that's not normal." And they got it fixed. So there's this kind of weird disbelief communication problem with patients who are recovering from InterStim. And if they're having issues, do the doctor believe them? And so in one extremely memorable case of a patient that I worked with, at month, she knew immediately there was a huge problem with it. They didn't believe her. They reprogrammed it for months. And they finally opened her up 3 months later. Her pelvis was filled with rusty battery fluid, and she had gangrene and permanent nerve damage because they made a mistake when they installed it and they somehow ruptured it. So imagine having rusty battery fluid floating around in your pelvis, and she's begging them and saying, "Guys, there's a problem. This is a problem." And they ignored her. They just placated her. And so I don't know how to defeat that. I actually had a meeting with a company about that. And because the company knows I'm a critic and they know that I empower patients to ask questions. You have to have a good relationship with your doctor, and you have to say, "Listen, if I'm telling you there's a problem with it, man, you got to believe me. I'm telling you there's a problem with it. It's in my body. Please take me seriously." The other big issue that I have with InterStim comes from a nurse who lived in a small town on the East Coast. There were 3 urologists in town. All 3 of them told her next step was InterStim. She didn't want to do it, but they kind of forced her into it. They basically said, "We won't treat you unless you do it." But she was smart in that she asked the doctor and the billing office in her doctor's office, "Is this covered by my insurance?" And they went, "Yes, no pre-authorization is required." Then she called the hospital and talked to the hospital billing office and said, "Is this covered?" And they said, "Yes, no pre-authorization is required." And then she did her due diligence and she called the insurance company directly and said, Am I covered for this?" And they said, "Yes, no pre-authorization is required." She woke up from the surgery. A week later, she had a bill for like $70,000 with a threat to garnish her wages because she was a nurse at that hospital where she had the surgery. And the mistake that she made is she did not get that in writing. And so if you are going to have InterStim, get in writing from the insurance company that you will be fully covered for it. Then the other point you've got to make, now listen, InterStim is not a one and done kind of deal. InterStim requires constant monitoring. You're going to be going back to the doctor several times a year to have them check it. And I had a patient call who lived in Florida whose device was malfunctioning and shocking her. And that's not unusual. I think she went through like a security thing that did something to her device. But she lost her health insurance. And the doctor who implanted the InterStim refused to see her, even if her device was malfunctioning. And so she couldn't find a doctor to care for this malfunctioning device. So she called me and we called the company. And it turned out in the state of Florida, only one doctor would take care of patients on Medicaid with InterStim. And it was like at the other end of the state. Whoops, sorry about that. And so an important question to ask your doctor is, if I lose my health insurance, will you treat me? And if the answer is no, you're going to say, then who will treat me? And if he says, I don't know, I think I would say, then I'm not sure I want to have a device that's going to require constant medical attention. Make sense? So I would do urgent PC first. Then least invasive, the fewest side effects. Shannon says, can you easily do installations at home? Yeah, you just got, the nurse will teach you how to do it. You just have to practice good sterile technique, and you don't reuse catheters. Robin said, I'm so glad you told me about the adverse reactions because I almost got it done in October. I'm glad you waited, hon. Yeah. I mean, InterStim is really, I mean, it's an option. If you were incontinent, fecally incontinent, man, it could change your life. If you've got severe pudendal neuralgia and we got to try to calm those nerves down, InterStim makes sense. But, you know, there are other forms first. I mean, neuromodulation makes sense. What exactly is urgent PC? It's an ankle stimulator. I have let me see if I can contort myself and show you I was one of the first patients who did it back in 1993. I don't know if you can see that. See that little black mark right there? That is a little tiny tattoo where they put the needle. So they basically just put an acupuncture needle right there, and then they attach it to a TENS unit. And when they turn the TENS unit on, if your toes bend down, we know we're on the right nerve, and you leave it on for 20 minutes and you do it once a week. And it retrains those nerves. And interestingly, when they do InterStim and they turn that unit on, they also look for the same toe flex. So that's how we know we're dealing with the same nerve. Ashley says, I've noticed that exercising actually takes my pain away. What does that mean about my IC? I think it points to physicality, Ashley. I think it points to maybe muscles. All righty, my friends. I think, listen, we've been going for almost 3 hours and I've had a headache for a couple of days with a sinus headache. And so I think we're going to call it here. I wish you a safe Thanksgiving. Please stay at home. Don't travel. Protect yourself and have your family gathering next summer. All right. So I send you all love and kindness and peace and joy. And I hope that you have a wonderful week ahead. And I don't know if I'll be doing one next Sunday. We'll see. We'll see how things go. But I'm just going to go ahead. Come on over to our website. Remember, you can buy the supplements in our store. And please sign up to become a subscriber so you can get our wonderful magazine. And we've been doing it for a long time. And it's just really a fantastic magazine for patients who want more information. It's called the IC Optimist. All right, my friends, I'm hungry. I got to go eat. I'll see you later. Have a good one. All right, Facebook is gone. All right, YouTube, I will see you guys later. Peace to you all.
Be well. We are in this together.